Hello everybody! First of all, I would like to thank my esteemed colleague, Professor Du Hongen, for inviting me to this 4th International Conference on Scoliosis Integrated Chinese Western Medicine in Hangzhou. I still remember very well the hospitality I enjoyed during my stay in Hangzhou last fall. I have very fond memories of that time, and I would like to follow up on our decision at that time to enter into a scientific collaboration with my lecturer. But now to the topic. Scoliosis is a three-dimensional deformity of the spine and trunk, which can have a wide variety of rare causes and different patterns of curvature. There are, among others, neuromuscular and myopathic scoliosis, scoliosis in connective tissue disorders and accompanying to various syndromes, as well as congenital scoliosis with malformations. However, idiopathic scoliosis, which are those scoliosis that cannot be attributed to any specific cause, account for the majority with 80–90% of all cases. There is much to suggest that idiopathic scoliosis is caused by a functional tethering of the spinal cord in the spinal canal, a partial adhesion of the meninges surrounding the spinal cord to the canal wall, possibly on the basis of a previously existing inflammatory process. Both pattern-specific physiotherapy approaches like Schroth and Monticone and brace treatment are supported by high-quality studies. Regarding surgical treatment, there is no evidence that the long-term prognosis after surgery is actually better than the long-term prognosis of idiopathic scoliosis itself. On the other hand, it cannot be assumed that the deformity of the torso can be significantly influenced by an operation. Studies are only available for brace treatment that show a significant improvement during the main growth spurt, or at least stop curvature progression. A series of adjuvant therapy procedures have already been used. However, so far, no clear evidence has been provided for any of these additional procedures. At the Zhejiang Provincial Hospital of Traditional Chinese Medicine, Tuina therapy has been used for many years as part of the traditional Chinese medicine, including for adolescent patients with scoliosis. Based on the experience gained from treating several thousand patients, it may be assumed that Tuina therapy has a positive effect on the progression of adolescent idiopathic scoliosis, we call short AIS, during the main growth spurt. This would be the H1 hypothesis. The scientific problem with the investigation of the H1 hypothesis is that it would be unethical to leave prognostical unfavorable scoliotic curves without brace treatment during the main growth spurt. Therefore, short-term controlled studies on physiotherapy for scoliosis in patients of growing age with minor curvatures and a rather favorable prognosis are almost exclusively available. This is a weakness of the studies published so far on the subject. The prognosis according to Lowenstein and Carson, which can be used to predict the risk of progression, may help to solve this dilemma. This method is still used today to make predictions and allow patients to be divided into a group with moderate risk of progression and a group with high risk of progression. Another weakness of almost all randomized studies on physiotherapy and brace treatment for scoliosis is the fact that the curvature pattern also has a significant influence on the prognosis and thus on the success rate of the treatment. A different weighting of the curvature pattern distribution in the control group and the treatment group may invalidate any conclusion, especially in randomized studies with a small treatment effect. Examples of this are the studies by Schreiber and colleagues, in which the small treatment effect in two differently treated patient groups was attributed to the short treatment. In one of the treatment groups examined, defined as the treated control group, there was a higher number of combined curvatures than in the short group. However, combined curvatures are less correctable than single curvature patterns. Thus, the treatment effect could just as well be attributed to the different curvature pattern distribution and not to the short treatment alone. Therefore, the study protocol must be chosen carefully. If one wants to ensure that the curvature pattern distribution is as homogeneous as possible in all groups to be examined, the study design of a prospective controlled study with matched pairs is an obvious choice. In this way, not only the curvature patterns, but also the age, menarche status, angle of curvature and sign of Risser could be homogenized. In order to generate groups that are as homogeneous as possible, one should also limit the study to girls during the main growth spurt, especially since the main growth spurt occurs at different times in girls and boys and also has a different dynamic. On the other hand, the gender-specific prevalence of idiopathic scoliosis also suggests a different prediction. The aim of this paper is to create a study protocol that allows little uncertainty regarding the quality of the results due to inhomogeneity. Having said that, the following study protocol is proposed. Inclusion criteria: otherwise healthy girls with adolescent idiopathic scoliosis, AIS, between the ages of 10 and 14 years, at least Turner 2, Risser 0 to 2, Cobb angle of curvature 20 to 45 degrees, without any previous treatment. The study design should be a prospective controlled study with matched pairs. Let's have a look at the group allocation. Roman 1, the Tuina group, with a risk of progression of 60 to 80%. Roman 2, Gensing embrace group, with a risk of progression of 60 to 80% as well. Roman 3, combined Tuina Gensingen brace group with risk of progression exceeding 80%, and Roman 4, Gensingen brace group with a risk of progression of more than 80% without any additional treatment. Groups with the same risk of progression are compared with each other, that are groups 1 and 2, as well as Roman 3 and 4. The risk of progression is determined according to the Lowenstein and Carlson formula. Groups Roman 1 and 2 and groups Roman 3 and 4 are matched according to curvature pattern, Risser stage, age ±3 months, and Cobb angle of the main curvature ±5 degrees. Menarche status is recorded but not used for matching due to the many factors influencing the time of the first menarche. For patients with braces, the percentage correction of the main curvature in the brace is also determined. For all patients, the Cobb angle of the secondary curvature and the thoracic and lumbar angle of trunk rotation, ATR, are also documented. If possible, the measured values of the surface measurement should also be documented. Let's come to the timeline. T0 is the initial examination directly before the start of treatment. The X-ray must not be older than 14 days. T1 is the 3 months checkup, T2 at 6 months, T3 at 9 months, T4 at 12 months, T5 is the 15 months follow-up, T6 18 months follow-up, and T7 24 months follow-up. And independently of further interim examinations, T8 final follow-up at the end of treatment, T9 6 months post-treatment follow-up, and T10 final follow-up 12 to 24 months after finishing treatment. Group Roman 1, the group with only Tuina therapy, is limited to the prognostically more favorable patient collective with a risk of progression between 60 and 80%. In order not to expose these patients to unnecessary risks, this patient group is followed up every 6 weeks within the first 12 months of treatment. If these interim examinations show a clinical deterioration, an ATR of 3 degrees or more, an X-ray examination is arranged. If a progression of the curvature of 6 degrees or more according to Cobb is detected during one of these follow-up examinations, the patient in question will be fitted with a GBW, a Gensingen brace. In principle, 2 research questions can be addressed with this study design. A. The success rate of Tuina therapy compared to the GBW, and B. In patients at higher risk of progression, success rate of GBW plus Tuina compared to GBW alone. In study A, the success rate of Tuina therapy alone can be compared with a calculated risk of progression. If Tuina therapy alone shows a significantly better success rate than the calculated risk of progression would suggest, the H1 hypothesis would be proven for this patient group. In contrast, the control group would reflect the results of evidence-based therapy with Gensingen brace, the GBW, which can provide information about the cost-benefit ratio of Tuina therapy alone versus GBW. The second question can be answered by study B, with patient groups Roman 3 and Roman 4, in which Tuina therapy is considered as an adjuvant therapy with the aim of finding out whether Tuina therapy as an adjuvant therapy can support evidence-based brace treatment. This study can build the bridge from current evidence-based patient care to traditional Chinese medicine and explore the possibilities and limitations combining both treatments. Na and colleagues have already conducted a feasibility study that indicates the possibility of a randomized controlled trial on this topic. Finally, I am pleased to note that the Genzinger brace, as proposed for this study, has already been recognized in the Chinese professional literature. I am really excited about our future scientific collaboration because I see great potential for further meaningful studies on the conservative treatment of patients with spinal deformities, including traditional Chinese medicine, in addition to the comprehensive study protocol described here.